They're all from Chinese chapters, and we are looking forward to have this meeting success. And I believe we can learn each other and obtain much more update information. So let's have a great welcome for the president of APSS, Professor Kwan, to have a welcome address. Welcome.
Thank you, Professor Yusun. Kwan here. Very welcome to all the participants, moderators, and most importantly, the speakers to this APSS webinar, the first time in collaborative with CSRS Chinese chapter. Asia Pacific Spine Society, also known as APSS, is well committed in terms of providing education and research for spine surgery. It is our objective to promote the arts and science of spine surgery for the betterment of spine care for all the patients with spine problem in the Asia Pacific region. Because of that, we routinely provide a lot of education events, and one of them is webinars. We have one webinar every 2 months, yearly. And for this year, and for this today, we have a very special webinars where we are in collaborative with CSRS China's chapter. So I'm very sure that renowned expert here will be able to give you a latest update with regards of the cervical spine surgery. There are many other education activities provided by APSS, such as basic spine course, advanced live operative course, as well as tablet course. We also provide a lot of fellowship program, offered to all Asia Pacific spine surgeons. Please check our website for more details. For this webinar, I'd like to sincerely thank Professor Kai Chow and Professor Yusun for taking an effort to make a very fantastic program. I looked through a program. It's very basic, but believe me, they will be full of latest update and knowledge. I'd like to thank them. I also like to thank the APSS Education Committee, Ajoy, as well as the online committee, Vishal, the Secretariat, Kaylin, and the team, as well as Ortho TV. And lastly, thank you to all the participants for joining these webinars and enjoy this webinar. Thank you.
Thank you, Professor Kwan. And hi, dear everyone. I'm Kai Chow, and the board member of APSS and active member of CSRS-AP. I'm the chairperson of this webinar and very pleased to organize this wonderful webinar with co-chair, Professor Sun Yu. We have invited experts and active member from the CSRS-AP Chinese chapter to talking about cervical spine surgery, from anterior approach to posterior approach, including surgeries of ACDF, ACCF, CDR, laminectomy, laminoplasty, foraminectomy, and the cervical pedicle screw technique. And this is the first time that the APSS Online Education Subcommittee proposed to conduct a scientific online webinar with faculties from China Spine Society. This webinar is also full supported from APSS and the CSRS-AP. So first of all, let me introduce our speakers. Professor Luo Zuojin, who is from Shijin Hospital, Air Force Military Medical University. Zhou Feifei from Peking University South Hospital. Chen Huajiang from Changzhen Hospital and Navy Medical University. Wang Beiyu from West China Hospital, Sichuan University. Sun Yu from Peking University Third Hospital. Xia Tian from Peking University Third Hospital. Zhang Hao from Shenzhen Longhua Hospital. And I'm from Affiliated Rehabilitation Hospital of Nanchang University. And Yang Junsong is from Honghui Hospital, Xi'an Jiaotong University. Professor Sun Yu and me are the chairperson of this webinar, and Professor Zhou Feifei and Zhang Hao are the moderators. So now I hand over the voice to Professor Zhang Hao, please.
Okay, thanks, Chairman. let's start this section about the anterior approach. Because the Professor Zhou Jinlu is very busy now, so the first speaker is the Professor Fei Zhou. Please show his pre-record video now. Welcome, Janet. Janet. Jennifer, please show the pre-record video. Yeah.
We cannot hear any voice.
Yes. Jennifer, we can hear your voice.
There's no voice.
I'm sorry, let me start again. Nadia, can you help me because can you screen share your
Jenny, if you have some problem, maybe we can move the Dr. Chen Huajiang. Okay. Okay. So.
I think the volume is still not coming.
Then if we can't hear the voice. Jenny, we can't hear the voice. Maybe we can invite the Dr. Huajiang Chen give us a lecture. Okay.
Jenny, we can't hear the voice of the video.
The
Okay, let
sound
me
is
try once
clear,
again. Yeah,
ma'am.
sorry for the hiccups.
Okay.
Would it be possible if Professor Fei Fei play your own video?
Beg your pardon?
Would it be possible if Professor Fei Fei play your own video? We share the sharing screen here.
Can I share my video with my own device?
Yes, please.
But I think you may transfer to the Professor Chen. And because I'm still in the OR, I have to go back to my office and share the video.
Nadia, can you stop the share?
Okay. Professor Hua Jiangchen. Professor Hua Jiangchen, can you give our lecture now? Okay. Professor Hua Jiangchen, can you share screen? Okay.
Hi. Okay. Let me share my screen. Oh, okay. Can you watch my can you see my screen?
Yes.
Yeah.
Yes, from
Okay.
Malaysia.
Okay. It's my honor to make a presentation here. Introduce about how to perform ACCF. I think every spine surgeon has his own experience on how to perform ACCF. This is a classic procedure. I just share our experience on this classic procedure. I'm Hua Jiangchen from Shanghai Changzhen Hospital. No disclosure. This is my hospital. My hospital is one of the most spine center in China. We performed over 16,000 spine operation per year and cover a wide range of spinal pathologies. So we actually perform a lot of ACCF procedure. As for the ACCF procedure, this is a classic procedure. It is familiar to every surgical surgeons. Since the time limited, I only focus on these six aspects. Includes indication, radiological assessment, position, special equipment, and surgical procedure details, and post-operation concern. The first is the number one is the indication. I think the ACCF indication a little bit different from the ACDF. ACCF procedure nowadays mostly applied for the very severe retrovertebral cord compression due to severe or degenerative disease and cervical spine deformity correction operation and cervical spine fracture operation and tumor and infection. Or we apply ACCF for revision surgery. So I think this is the difference from the ACDCF indication to the ACDF. Before we perform our ACCF, I think some point we must pay attention to. The first is the bone quality, especially in the elderly patients. If the patient with very severe osteoporosis, maybe it's a contraindication for ACCF. And we also usually avoid 2 or 3 levels corpectomy because long-term constructor may increase the risk for the hardware failure. And then we must perform some radiological assessment. If the patient not only have the myelopathy, and the patient also associated with the very severe radiculopathy, we must use the CT scan determine whether the level needed for uncinate resection. And for the deformity cases, we must evaluate before surgery. Before surgery, the patient, the deformity is a risk deformity or semi-risk deformity or flexible deformity. We can evaluate this use the traction preoperatively. This case is very severe, I think, rigid kyphosis with the neurofibromatosis. We performed the surgery several years ago, and after long-term follow-up, the outcome is satisfied. And for the OPR patient, if we want to do the ACCF, we must use the CT scan, assess the patient, the OPR. That's the OPR with the dural ossification. If the OPR with dural ossification, we very cautiously during the surgery, we must prepare something for the dural CSF leakage. And we also must use the radiological assessment for the some anomaly of the vertebral artery. For this image, we can see the left side vertebral artery enroach into the vertebral body. If we perform the ACCF for this patient, we be very carefully for make the trough. Before we perform the ACCF procedure, I think some special equipment is necessary. We must use loops for magnification, use high-speed bones and ultrasonic bones, scalpel for precise bone cutting. And sometimes we can use microscopy or neural monitoring for the safety, for increases the safety of the procedure. After general anesthesia, the first thing is the position. Usually we place the patient into a slight supine position. If we perform the ACCF is above the C3, we usually recommend use the nasal trachea intubation. If we deal with the very severe cervical stenosis or OPR or tumor resection, neural monitoring is necessary. For the incision, we usually use transverse incision. If we must perform 4 levels decompression, we usually use 2 transverse incision. After exposure, is the retractor placement. I think there's some nuances for the retractor placement. We always remind the assistant periodically relieve the retractor, avoid forced retraction, because the forced retraction may cause the esophagus and lungs colic ischemia, which will increase the risk of Horner syndrome. Then is the cuspal pin placement. We recommend not to close the end plate. And if we do the kyphosis correction operation, we implant the pin into a convergent method. So we can, which will help to correct, restore the alignment. For the decompression sequence, we usually decompress the severe compression firstly. The first thing we do is totally remove the disc. Then we use the Carson and the Ranger to cut the vertebral body to prepare the space for the neural element decompression. We must I think we must use sometimes we slightly separate the longer collateral muscle to obtain the enough space for exposure. If we perform the pulpectomy, usually does not need to extend the lateral beyond the uncus. We can also use the high-speed drill to delicately prepare the bilateral wall of vertebral wall. Usually, if we do the ACCF, we need expanded decompression, self-laterally and caudally. We always use some curate or Carson Ranger to achieve this procedure. For the OPL removal, I think there is some controversial for the OPL removal. But if there is hypertrophic compression due to the OPL or disc herniation behind the PL, we must remove the PL. For this case, it's a very severe osteophyte with hypertrophic PL. So we remove the PL and obtain, I think, sufficient decompression of the neural element. If there's a OPL, if we want to resect the OPL, we usually use the burn high-speed drill to thin the residual posterior wall and the OPL complex as thin as possible. And then we use the Carson to cut the OPL. We must avoid any downward pressure to avoid the neural element injury. And during this procedure, I think the hemostasis adequately is very important to very clear vision. I think the very clear vision is contributed to the safety of the operation. If the patient with very severe radiculopathy and there is severe stenosis of the nerve root canal, we must perform partial or complete uncinectomy. For this patient, we performed uncinate removal. After the decompression, then we needed the end plate preparation. Includes denude the cartilage and retain the cortical bone of the end plate, and we prefer the bone graft or the titanium mesh. And last, I think, maneuver is the plate and the screw. And we must prepare the plate for restore the lordosis, and the screw at least 5 millimeter to the end plate. Not to compromise the adjacent segment. For some osteoporosis cases, we recommend a bicortical screw fixation. After these maneuvers, we usually use a fluoroscopy to confirm the mesh position, confirm the screw length, and reassess the alignment of the cervical spine. And post-operative, we usually recommend to see the patient wear the collar for minimum 6 weeks, and at the follow-up, we will assess the bone quality, deformity progress, and pseudoarthrosis, and to assess the need for additional posterior fixation. I think since the time limited only 10 minutes, so I just briefly go through the indication, radiological assessment, position, special equipment, surgical procedure detail, and post-operation concerns. I think we pay attention to this perfect, then we can obtain a perfect ACCF. Thank you.
Okay, thank you, Professor Chen. Next speaker is Professor Wang Beiyu. His topic is how to perform the perfect CDR. Welcome. Beiyu.
Okay, if the PPT slide is okay?
Okay.
Okay. Dear the orthopedic fellows and spine surgeons, I'm Dr. Beiyu Wang from West China Hospital of Sichuan University, China. It's my honor to share my experiences about how to perform a perfect CDR. Okay. Performing a perfect cervical artificial disc replacement involves several crucial steps and consideration to ensure the procedure is successful and provides the best possible outcomes for the patient. So the goals of the prosthesis replacements, the first one is safety. The second one is stability. And the third is prosthesis position. And the last one is mobility. As we know, the different prosthesis designs have a different surgical logic. So let's take a Prestige LP for example. We need to complete 6 surgical steps in sequence. The step 1 is the end plate preparation. The first, we have to evaluate before the surgery about whether the ADR prosthesis can match the end plate. So the most of the time of the answer is mismatched, because the body end plate has a dome shape and the virus in the morphology, but the shape of the prosthesis is predetermined. From our clinical research, the classifications of the sagittal inferior endoplate morphologies of the Chinese people, about 27% of the people have the apex positioned anteriorly, and 53% centrally, and 19% posteriorly. And also, the different vertebral segments are distributed differently. But also, in a coronal position, the concave type is the most common, and the end plate width is smaller in a C2, 4 to 4, and larger in a C5 to 7. So the question is, what is the strategy for deal with the end plate mismatch? Green the anterior and the posterior edge of the end plate, is that the right answer? From our experiences, excessively green the anterior edge, that will reduce the support from the anterior end plate and increase the risk of the anterior collapse and the prosthesis displacement. Excessively greening the posterior edge, that will loss of sufficient support at the posterior edge. So the patient after surgery in the neutral position, the poor prosthesis posture and the limited mobility will be observed. Therefore, we believe that only the A and P edges can be properly graded. Intraoperative end plate grading angle is between 3.6 to 6.2 degree. Then the prosthesis may gain a good posture and mobility. In step 2, the selections of the trial mode is also important. The choice of the height and the depth is a hot topic. We can use 2 intraoperative viewpoints to help us make reference for the selection of the trial mode. This case is worthy of reflection. In order to achieve greater implant stability, we choose a higher model. But in the end, after the implant was placed, we found that the facet joint presenting a subluxation state. So this case finally had an intraoperative alteration to fusion. Step 3 is bone rasp. The key point in this step is to ensure that as much of the end plate as possible can be sanded. In this patient, height 6 was difficult to covering the most dome of the end plate. So we used height 7 to sand the anterior part 2 or 3 parts of the end plate. In this way, we can observe the sanded end plate is rough. In step 4, the drill is prepared for the bone groove for cutting. It is important to recommend a lateral X-rays at this step, where the depth of the drill is indicative of the effective depth of the implant. In step 5, the cutting is the most powerful step in the entire replacement state. After the tapping, it's recommended to have the lateral X-rays to ensure the effective cutting depth. This is the case of the active bleeding after a cutting. We found a fracture at the posterior edge of the end plate. So we stopped the replacement and artery to fusion. The post-operative 3D CT scan confirmed the cutting-related fracture. In this step of the prosthesis implantation, we need repeatedly confirm that the plate crease is right in the bone groove. After implantation, the position, depth, balance, status of the facet joint, the sequence, and the posture of the prosthesis must be confirmed by AP and lateral X-rays. Finally, through the correct replacement surgery, the post-operative patient can obtain a long-term stable and functional motion preservation. So, on the basis of the safety and internal fixation, the stable movement is required. In pursuit of the fixation and movement, it's essential to maintain a balance at all the time. We must notice that the requirements of the replacement surgeries are really high, and the different designs of the prosthesis have the different operation logic, which requires us to carefully prepare and choose the CDR surgery. Thank you for your attention.
Okay, thank you, Professor Wang. Professor Fei-Fei Zhou, can you share screen now? Yeah.
Can you see that?
Yeah.
Yes, we can.
Is there any audio here?
No.
I can hear
Still.
that.
Oh, the same problem.
I can hear the the audio and all of the sound here. How can we solve that? I can hear that.
Maybe there's some problem. Can you show the PowerPoint?
Because there's another computer here, so I didn't bring my PowerPoint here.
Yeah.
How can I solve this?
I think the Zoom software cannot match the various vision of the PowerPoint.
No.
No, we
No
can't
sound here?
hear the voice. Yeah. Maybe we can have the discussion now. Okay. Chairman.
Sure.
Okay. Thanks, Professor Zhou. Yeah. Do you have question to the Professor Chen and Professor Wang?
What's that?
May I ask Bei Yu a question? And what's the most the majority of complications you met in your clinical experience of a CDR in terms of short and long-term complications?
Okay, thank you for the Professor Cao. In our experiences, the long-term complications of the ADR might be the loss of the motion. So from the radiography, we can see some of the patient have the osteophytes in the backside, and some of the anterior parts of the bone absorptions from the anterior part. But we are lucky that we don't have dislocation and do the revision. Okay.
Thank you.
Yeah. I have a question to Professor Chen. Professor Chen. Yeah.
Okay, I'm here.
Yeah, thank you. You know, sometimes we use the 3D print implant in ACCF to prevent the subsidence. What's your opinion?
And 3-segment prevent subsidence. Because if we want to perform the 3-level decompression, if we have to use the ACCF, we always combine the ACCF with the ACDF to avoiding the 2-segment corpectomy. Because for long in construction, increase the subsidence rate post-operatively, and it's may increase the risk for constructor dislodgement, especially at the elderly people. I recommend Professor Zhou Feifei answer the question again, because I think topical we and we are almost the same. ACTF.
Professor Zhou?
Yes, I'm here.
Yeah. Professor Chen, and
So,
yeah, you can answer. What's your opinion about the 3D print implant to
I
prevent
think
the
it
incident
can.
subsidence?
I think it cannot be avoided the subsidence after the ACCF only by the 3D point construct design. I think there are many details during the procedure of the corpectomy, and also about the bone quality of the patient. So it's not rely on only the 3D point construct. Okay, Professor Zhang, I think I find my PowerPoint here. So may I just share my slide and just finish my part?
Yeah. Welcome.
And I think there's lots of questions from the audience. The number one, the first question that's I think it's to Professor Chen. In cervical kyphosis, the kappa pins should be placed in a convergent model. He asked the reason why. Why not in divergent model? Professor
I think this is the wonderful question, because for kyphosis cases, if we place pin into a convergent model, when we put the cuspal, then we can gradually, I think, a little bit space the posterior element will contribute to restore the alignment. But I think this technique cannot be used in osteoporosis cases, because if you place the convergent model of the pin in the osteoporosis cases, then when you put the cuspal, maybe some bony breakage occurred.
Okay, and Professor Zhou, can you show your screen for your lecture now?
Can you see my slides?
Yeah.
So it's sorry. Is that audio here? You can hear anything? No?
No,
Can you
still
hear
not.
anything?
Yeah.
Okay, I just remove all of the audio here, and I will do that. Wait a moment. Okay. Is that the slide here? The full screen pattern, right?
Yeah.
Yeah, we can see it.
You can see can you just hear me?
Yeah, we can see the slide, but
Yeah.
there's no voice. There's no
Yeah, I will.
audience.
Yeah, I will talk right now here. I just
Okay.
just speak here. Yeah. So the topic I want to talk today is how to perform a perfect ACDF. I think it's really I have nothing to disclose, and I think it's very hard to define a perfect ACDF. So in my point of view, I think a perfect ACDF depends on three aspects. It's about accurate diagnosis before the surgery, and also the precise operation during the surgery. I think is the most important step. And also we need some advanced instrument and equipment. So first one, I want to talk about the accurate diagnosis before the surgery. We need to make sure the qualitative and the quantitative diagnosis before we operate on any patient, because we need to find out the specific pathogenic factors, and not only the static one, and also the dynamic or the instability of the cervical spine. And most important, I think we need to find out the patient request based on the medical history and also the background of the patient. We need to find out the relationship between the structure and the function, and also the physiological function and the pathological state. Because there's a lot of static structural compression to the cervical spinal cord in cervical spine. For example, the disc herniation, the osteophyte formation, also the canal stenosis. And we also we can find the dynamic stability state. Of course, we need to give the patient many tests before the surgery, the X-ray, CT, MRI. And of course, we can find the degeneration from the disc, from the osteophyte formation, and also from the end plate. Before the surgery, we can find out the degeneration state of the cervical spine. And we also pay more attention to the curvature, not only the oral curvature, and also the regional alignment of the cervical spine. And we need to find out whether it is a rigid or it's a flexible cervical spine, as mentioned by Professor Chen earlier in the ACCF procedure. And also we need to find out the stability, any sleep angulation of the cervical spine, and we all need to find out the distance between the spinal process and also the relation between the facet joint, whether it's a parallel or it's an angulation. Recently, we pay much more attention on the sagittal balance of the cervical spine. We calculate the C2 to 7 SVA and a T1 slope and so on. And of course, we need to extend our view to the whole spine. And we can find any bone structure, the osteophyte formation or the spinal stenosis from the CT. And also we can find the calcification or ossification of the ligamentum structure. And we need to pay more attention, not only the bone window, and we need to pay more attention through the soft tissue window. And we can measure something through the CT scan. For example, the CT value before, for example, we play ACDF or ACCF. I think MRI is our most relied radiographic examination, and we found anything wrong about the neurologic system, and we can find the PLL and also the iliac ligament hypertrophy and we can find some soft tissue, the vertebral artery, and also some modic change through the bone structure through the MRI. So it's a pre-op preparation before we operate on the ACDF. Of course, we need to make sure our preoperative planning before we operate. Let's take a patient, for example. It's a 40 years old male patient. The chief complaint of the patient is numbness in both his hands for the past 12 years, and he suffered pain in both shoulders for the past 6 years. And he had the limited fine motor skills in the right hand for nearly half a year. So we can see the grip strength decrease for both hands and hypersensitivity of number 2 to 4 fingers on his right hand, and the hyperreflexia and the positive Hoffman sign. And we can see the MRI and CT scan. We can see the multi-level degeneration and cord compression, and also some foramen stenosis from the level of C4-5 and C5-6. So before we operate an ACDF, we make sure the extent we need to remove the ossified posteriorly of the vertebral body, and what the longitudinal distance we need to decompress. And we also can calculate the exact height we need to operate. And there's a classical exposure, and we need to remove the anterior ligament and remove the part of the disc, and we need to prepare the disc space, remove all the disc, and we prepare the Casper pin. I think in our hospital we use the Casper pin in a parallel, the unilateral in the vertebral body, and we can use the hole when we put in the plate. And then we just to distract the disc space, and we always choose the parallel distraction, use some device, make it the posterior part of the vertebral body can be distracted well during the decompression surgery. So when we just decompress the disc space through the ACDF, we should follow the sequence that we just make sure the bone window that we need to remove the ossified first. We need to use a correct or the burr or something, the tools we can use. And then we just expose the PLL and remove the PLL, and we find the clap disc behind the PLL and within the canal. So we can see multiple tools to remove the ossified. We can use a Carrison, a 1 millimeter Carrison or 1.5 millimeter Carrison. And we can also use a burr to remove the posterior part of the ossified. I always use a diamond burr to remove the posterior margin of the ossified like this. And when we just depose the PLL, we use a pen-filled Holker and make the calculation of the disc and to prevent the bleeding. And we can also use the pen-filled to lift the PLL up and find the bleeding here, and just use a bipolar to stop it. So I think I should pay more attention on the decompression with the ankle-vertebral joint, because there's some foramen stenosis, and in some point or occasionally we need to remove the ankle-vertebral joint. I think we need to first remove the enough disc at this region and to expose the media and posterior part of the uncus, and we can use the same. We can use the Carrison, or we can use a burr to remove the ankle-vertebral joint. So that's why I mentioned a lot of tools we can use during the surgery. There's a lot of I mentioned the pen-filled, the Carrison, and we should use more microscope, because we can use under the microscope, we can use a microsurgical instrument, and we can use some power system like high-speed burr or ultrasonic bone cutter. So under that sequence, we can make a very good ACDF, the decompression, the alignment, and also the position of the implant. So let's to go to the take-home messages. First, I think we need to focus on the right patient. We need to combine with the medical history, the physical examination, and the radiographic data to make a clear diagnosis. And also we need to do the right surgery. I think during the surgery, I think there's a sentence that the devil is in the details. And the last one, we need to operate the right surgery on the right patient. That will make the ACDF perfect and make our patients safe and had a satisfied outcome. Thank you for your attention.
Thank you, Professor Zhou. We just have 3 minutes to discuss in this section. And participant online ask a question to Professor Chen. Professor Chen, what's your experience with the standalone and a cage with a space?
Okay, and according to the stand-around cage, I think stand-around cage we have used in the anterior procedure, but we always use the stand-around cage with the screw, such as the cerebral plate instrumentation. If we only use the stand-around cage, from our experience, which will increase the ununion rate and increase the pseudoarthrosis rate. So we recommend stand-around cage with screw. So, but on other hand, maybe the low profile instrumentation can decrease the dysphagia post operation. Okay.
Thank you. The next question is to the Professor Zhou, and a participant online asked any other tips to prevent the Horner syndrome. What's your opinion?
I think that some details when you just you expose this space, you may to remove part of the medial part of the longus clavi. So I think the sympathetic nerve line is just under the 1/3 of the superficial of the longus clavi. So you may not use your bovie just to cut the longus clavi from the surface to the bottom. You need to from the bottom to the surface. You just go to the connection part of the longus clavi and your vertebral body. Just leave it off as you need, and then can be a very effective way to prevent the Horner syndrome.
Okay, thank you, Professor Zhou. There are two questions ask you. So because the time is over, so please answer questions online. Thank you. We move to the next section, Professor Zhou. Okay.
Okay. I think it's my turn to moderate to the next session. I think next session is focused on the posterior approach. The first speaker of this session. Okay, it's about the keynote speech indication and complication of posterior procedures. Speak by Professor Sun Yu. Okay, Professor Sun, are you ready for that? Okay, it's your turn.
Okay, so I'm going to talk about this indication and complications of posterior cervical procedures. Nothing too difficult. So before we talk about the indication, we should understand the principle of posterior procedures for cervical spine. The first one is the decompression by means of to enlarge the spinal canal to relieve any compression on the spinal cord. The second one is any compression on the nerve root. So we need to enlarge the neuroforamina. The second part is the stabilization by means of any fixation means to fix any segmental instability and any iatrogenic instability which due to decompression causes the segmental instability. And the third one is the realignment, that means to restore the physiological curvature of cervical spine. So once we understand the indication of the principle, then we can understand the indication for that. The first one is cervical myelopathy. There's so many pathologies cause cervical myelopathy. The first one is multi-level disc protrusion and osteoid formation, and even on the compression on the anterior part of cervical spine, but it's 4 or 5 levels compression. The second one is developmental stenosis or degenerative stenosis. It causes bilateral compression on the spinal cord. The first or third one is multi-level OPL. You can see so many levels. It's more than 3 levels OPL. They must be decompressed posteriorly. And also the multi-level OLF, the ossification of yellow ligament. You can see the spinal cord also compressed bilaterally. And the last one, it's not very common, but it can be seen sometimes, is the skeletal fluorosis. And that means you can see the spinal cord was severely compressed. The second part is the any pathology called cervical reticulopathy. That means in lateral disc protrusion, actually shown in 2 cases. And then another one is ossified formation on the uncovertebral joint. So for the reticulopathy, and also sometimes we can see ossified formation on the uncovertebral joint and cause a very severe decompression on nerve root. That's the case we done 10 years ago, and as a case shown earlier. And at that time we didn't have any endoscopic process devices, so we used the open procedure and work internal to relieve all the compression on the spinal cord and the nerve root. So the current procedures for cervical spine, and including for the purpose of decompression, is including the laminoplasty, laminectomy plus internal fixation, and foraminotomy. And also we can use the lateral mass screw fixation and fusion or pedicle screw fixation to achieve a stabilization. So the laminoplasty has been performed worldwide in preference by the most surgeons. The first open laminoplasty developed in 1970s by Japanese surgeons, but they has a problem with door recross. So nowadays, with the mini plate on the opening side to keep the doors open has become a standard procedure. Another procedure is the French door laminoplasty developed also by the Japanese surgeons. The laminoplasty, the laminectomy, developed first by the Japanese surgeon, but it has a disadvantage. Most seriously, it's a malalignment of cervical spine. So nowadays, laminectomy plus internal fixation and fusion has become a standard procedure for the posterior decompression. And also keyhole procedure has become a standard procedure. Nowadays, many surgeons use the endoscopic surgery. I think will be presented by Dr. Jin Songyang later on today. For the posterior fixation, I think the last mass screw fixation fusion was most common, which is developed by Dr. Magamil in 1920s, in 1970s. And pedicle screw fixation was developed by Professor Abumin in 1970s as well, and use a fixation. Now it's a demographic show the difference and the lateral mass screw fixation and the pedicle screw fixation. So after we talk that, we have to understand some special pathologies for the cervical myelopathy. First one is the patient with a multi-level disc compression, but with 1 or 2 level huge disc protrusion and a large osteoid formation and local, and also maybe combined with local kyphosis. So this is just an example of that. So for these pathologies, I think the posterior procedure is the first choice. I may be considered to have anterior procedure on the secondary stage or one stage according to the patient's general condition. And with the local kyphosis, with quite severe procedures like this, you can see on the extension, the patient can only correct these kyphosis to the street. So that means not very well. But from literature, we can understand the local kyphosis is less than 30 degrees. Then we can just perform the posterior procedures. But if high signal change, the local kyphosis must be less than 5 degrees. Otherwise, you cannot reach a good result. So this is the example of that we can understand for one stage anterior and posterior decompression with a laminectomy plus lateral mass fixation can have a good decompression or correction on the cervical curvature and can achieve a good outcome. This is just an example from that. Use the pedicle lateral mass screws. And also maybe you can use the pedicle screws to correct the kyphosis as well. And the pedicle screw fixation has a much more power to correct this kyphotic angle. Of course, maybe you can choose the second 2 stages for the correction. You can perform the anterior posterior first, then convert to the anterior as well to correct the cervical kyphosis. But for the OPL, and we have the special situations like discontinuous type. For this one, then we can consider to multi-level internal fixation fusion. And in that term, we can either correct the cervical curvature and also the long segmental fixation fusion may stop growing of OPL. But local occupied OPL, then we can consider the separate one stage or 2 stage combined surgery. But for the key line, OPL is a special topic of that. So before that, we must understand the pathology of the key line. One is a kyphotic, other one is OPL is too large. So in terms of the kyphotic, then we consider 2 procedures. One is the posterior procedure combined with anterior procedure, just like this literature reported. And also maybe consider the combined procedure, circumferential surgery with one stage or 2 stages of that. So in terms of complication of posterior procedure of cervical spine, there's so many complications. We can consider this as the procedure related, approach related, and instrumentation related. So because the time related, we only talk about a few complications with laminoplasty. Generally speaking, is much less than the laminectomy, but the serious complication must be considered. One is motor road palsy and axial lordosis. Now, axial symptoms. So for the motor road palsy, as we understand, the C5 palsy has been reported. It happens normally during the day 2 until day 9 after the operation. And most C5 palsy will happen at the unilateral side. And also in comparison to the 2 procedures, the open door laminoplasty may be higher than the French door, and the OPL have a much higher incidence of C5 palsy compared to CSM. So the principle of that is many authors to team to this the tethering mechanism is because due to some hypertrophy of superior articular process, and also because the CF palsy is shortest and the nerve root, and during the decompression, the nerve root was stretched. And there's some literature about the prophylactic femorectomy to reduce the incidence of C5 palsy. From literature, you can see is quite effective. But for the treatment of C5 palsy, and the most of the patients will get recurred with a conservative treatment, and 95% patients will recovered within 3 to 6 months after surgery. So another complications is the axial symptoms, or it's called axial syndrome. And the incidence is varied from 60% to 60%. The incidence of the severity of the axial syndrome is varied, and there's so many means can reduce that. I think there's first 3 is most important. We try to get less invasive and preservation of posterior muscles and ligaments, and also to provide the hinge side stability. The Japanese surgeon has done some studies to try to reduce the axial syndrome with the preservation of C7, C2 muscular attachment. And also, they have tried some modified procedure to preserve the muscular ligament complex, which reported the first time in the world in 1980s. Is the preservation of unilateral muscular ligament complex. So our hospital started in 2006 and started using the preservation of unilateral muscular complex. So the long-term follow-up showed this procedure to maintain the range of motion and protect muscles, and then finally to reduce the incidence and severity of axial syndrome. And also another Chinese surgeon from Wuhan and has reported modified his open door laminoplasty, also with the preservation of unilateral muscular complex. But for the Japanese surgeons, they try to preserve the bilateral muscles. They introduce a trans-intramuscular space approach, and described by Dr. Shiraishi in 2001. It's a French open laminoplasty trans-intramuscular space approach. And also he reported with muscle preserving procedure, so in selective laminectomy, reported has less instance of AS. And in China, and Dr. Dao Chunlin from Zhengzhou, Henan Zhengzhou reported is endoscopic trans-muscular space approach for the cervical expansive laminoplasty. Formally reported, and we can see that sagittal diameter can increase 1 to 3 millimeters. But from 2014, 10 years ago, we started our procedures like the raising roof procedures, just like the whole lamina had been raised backwards to enlarge the surgical diameters. Then they used 3D printed models to insulate the gap to resolve cervical canal structures. And so this is just an example of that. So we can understand we perform this just like this. First one, we cut this one side and open it on one side and put an implant and cut the inner cortex on the other side and to put the 3D printed implant. So the spinal canal could be enlarged. So on 12 months follow-up, we can see the range of motion is well preserved. The spinal canal was decompressed. At 12 months follow-up, we can see the spinal, the implant has fused with lamina. So we have reported our early stage. We can see this raising roof procedure compared to the traditional one. It has achieved the same neurological function improvement, but most importantly, it has more advantage in maintaining the central balance and cervical range of motion. Now it's just published online. It's our study. It's compared to the 4 different procedures. The last one, D, is our raising procedures like this. And we can see the axial symptoms most dramatically decrease with the raising procedures, and also show the less severe palsy compared to laminoplasty, the traditional laminoplasty. Nowadays, the posterior procedure has still on the way to improve that, and I believe as a technical improvement, the surgical procedures will get much better and better, and also reduce all the complications and to improve our clinical outcome. Thank you for listening. Dr. Zhang.
Yeah, thank you, Professor Sun. Give us very detailed information about the indications and the complications of the posterior procedures in cervical spine. And next, we would like to introduce the next speaker, Dr. Xia Tian. His topic is how to perform a perfect laminoplasty. Dr. Xia.
Okay. Good afternoon, distinguished experts and attendees. My name is Xia Tian from Peking University Third Hospital. I'm really honored to share my experience in this webinar organized by APSS. Today, the topic I'm talking about is how to perform a perfect laminoplasty. The expensive Z laminoplasty was the first type of laminoplasty developed by Professor Oyama and Hattori in 1972. And this procedure was designed to prevent postoperative invasion of the membrane, which was presumed to cause late deterioration following surgery, but has not become popular because its technical complexity. And in 1977, Professor Hirabayashi devised a simpler technique of expensive open-door laminoplasty of unilateral hinge type. The long-term follow-up showed excellent clinical results. And Professor Kurokawa in 1980 developed double-door laminoplasty. And since then, the latter two techniques were widely used among spine surgeons. And I think the indication for laminoplasty were well addressed in the previous lecture given by Professor Sun Yu. And for the comparison between the two techniques, I think the single-door laminoplasty is simpler, but might have higher incidence of irritating the venous plexus and the nerve root if the location of open-door gutter is not very ideal. And the sidedness might affect some clinical outcomes, maybe related to the recovery rate or the complication. And the French open-door laminoplasty is a little bit more time-consuming, and the technique would not irritate the vessels and nerve root, but instead, it might irritate the spinal cord when splitting the lamina, especially in the cases with very high occupational rate. And for the surgical techniques, the first step is the preparation and the positioning. I think during the anesthesia, hyperextension of the neck should be avoided to prevent iatrogenic spinal cord injury. And both Mayfield and Gardner-Wells tones would facilitate the surgery and elevate the upper body about 20 degrees to avoid congestion of venous plexus. And also, we should avoid hyperflexion to prevent the hypoglossal nerve to be pinched by the anterior anatomic element, and which can cause Tapia syndrome, which was the hypoglossal nerve palsy. And for the approach, the conventional midline exposure could be used for this surgery. But nowadays, surgeons are discovering several modifications during the approach for better muscle preservation. And now we are using the gap between the semispinalis capitis and the semispinalis cervicis is more and more used to complete the surgery. And in this picture, the muscle clamped by the forceps is the semispinalis cervicis, and the semispinalis capitis is extracted by the suction, and the the blue line and the blue dotted is just the fat tissue between the two muscles, and we are just using the gap to complete the surgery, the gutter and the open door. And when making the hinge and the trough, you can use either a roundurer or a high-speed burr or ultrasonic osteotome, which you are familiar with. And the key point is the ideal position of making it. And you can use hook tip pen-fill filler and slide it just along the inner cortex of lamina. And when it's blocked, and you cannot make it further lateral outside, and is the ideal position to make the gutter. And it's just showed on the video. And on the open side, the core technique is basically the same, and find the ideal position to make the gutter and take cautious to minimize the invasion into the spinal canal. And at this point, you should be able to elevate the lamina with gentle force. And if you feel strong resistance, you should cut the ligamentum flavum. And if still not work, you should recheck the hinge if the hinge was properly made. And the lamina might be opened at a proper distance between 10 and 14 millimeters if you are using the mini plate. And sometimes you may encounter heavy bleeding, and if it's from the osteotomy side of the bone, you could use the bone wax to seal the cancellous bone. And if it's from the venous plexus, you could try to use bipolar to turn it into a very gentle force for hemostasis. If it's still not work, a tamponade is helpful. And after hemostasis, leave minimal materials in the spinal canal. And finally, was the plating. And you should be cautious with the screws. Do not penetrate the lamina or into the articular space. And wound closure is very crucial for the surgery. And after a thorough irrigation, the wound should be closed in layers by layers, and following the sequence of muscle, fascia, subcutaneous tissues, and the skins. You should suture it for at least 4 layers. And when suturing the muscle, align gently to avoid excessive tension that may cause muscle ischemia or pain. And the fascia should be as tight as possible to isolate the wound. Additionally, layers may be added if necessary. And before the end of surgery, a cocktail wound block using lidocaine and ropivacaine is used to minimize the pain. There are many details involved in one laminoplasty case, and the key points include proper positioning, minimal invasive concepts during the exposure, and making the gutter in a proper location, and finally the wound closure. So that's my experience about how to perform a perfect laminoplasty. Thank you for your listening.
Thank you, Dr. Xiatian, share us the peers and pers about the laminoplasty. And we will move to the next speaker, Professor Zhang Hao. He will give us a topic on how to perform a perfect laminectomy and fusion. Professor Zhang, please.
Okay, thank you, Professor Zhou. Can you see my screen now?
Yes, please go on.
Okay, thank you. My topic is how to perform a perfect laminectomy and fusion. I'm Dr. Hao Zhang from the Shenzhen People's Hospital. Posterior cervical laminectomy and fusion delivers a compression and increased stability. In 1891, partial first attempts of posterior fixation into spinous ring with long graft, and Howard and Hardy in 1953 better result by using the spinous ring and grafting. Indications and the congenital or development cervical stenosis and the OPR-K9 and negative and occupying more than 50%, and interspinal space occupying ligamental fragment tumor and hematoma, and damage of the rear adnexal structure, multi-compression segment more than 3 levels. Other situations that require interspinal exploration. Compared with the laminectomy and laminoplasty, laminectomy and fusion have the most spinal cord stress and strain during the leg flexion, extension, natural bending, and axial rotation. Assessment beneath the accuracy of the neutral and natural position and flexion and extension position, and the cervical CT and 3D reconstruction and MRI. This is accuracy and columnar sagittal and flexion extension. There are 4 line measured cervical corpus angle, and we must notice the cervical 2 to 7 as we to know the sagittal balance. This is a CT scan and MRI. We must know the dynamic MRI, sometimes very important, diagnosis. Operation, pre-operation, we must measurement and implant and selection, and intraoperative the medication, and we must know the C5 nerve passor prediction and reduce the shoulder traction. This is operation. This is a military posture, buckling head with a middle extended neck. It's an exposure. Fixation, we use the net mass screw and the pedicle screw. This is a pedicle screw. We must know the depth of the pedicle screw. The compression, the use of the ultrasonic osteotomy can significantly reduce the bleeding volume and the dural tear rate. Laminectomy with fusion could in a slight reduction in the cervical nodosis angle about 6 degrees and may require more revision surgery in 5 years. We must prevent the hemostasis, so sometimes with the surgical flow. Post-operation, we must mention the C5 nerve palsy, hematoma, and remove the drainage tube less than the 15, and then while in a leg brace with the mouth opening slightly limited. We show the 2 cases. The first case is a female, Ismail, 57 years old, OPR from C3 to C6. Yeah, this is CC and P. JOE is 11. This is a pre-operation scan, accurate CT scan and MRI. It's a post-operation. JOE is 15. The recovery is 67%. Intraoperative blood nose is 150. Nose C5 no palsy. This case 2 is a female, 74 years old. It's a multilevel CSM. JOE is 12. Pre-operation is actually CT scan and MRI. We used the laminectomy from C2 to T1. So JOE is post-operation. JOE is 15. Recovery is 60%. Intra-operation blood loss is 110. No C5, no passes. Take-home message: grasp the indication of the surgery. Comprehensive the pre-operative imaging data is required. The target pre-preparation and assessment. Familiar with the surgical procedures to reduce the operation time, blood, nose, and post-operative complications. Thanks for your attention.
Thank you for the sharing by Professor Zhang Hao. So the next topic is how to perform a perfect cervical pedicle screw placement, presented by Professor Cao Kai. Professor Cao, it's your time.
Okay, and I will share my PPT.
Zhang Hao, you should quit
Oh, okay. I know.
screen sharing. Yes,
Yeah,
that's
okay.
good.
I'm sorry.
It's my I'm Cao Kai. It's very pleased to share our experience to perform a perfect cervical pedicle screw placement. And as we know, there is various techniques, including freehand navigation, robotic CT cutout, screw guide template, has been developed to implement the cervical pedicle screw. But the mastering in freehand techniques allows the above-mentioned technique to reach their full potential, improving patient-reported outcome. And currently, freehand techniques are still prevailing in particular scenarios, and the problem is lead to inadequate accuracy in the below scenarios. So we find a consistent anatomic landmark and develop a practical and easy mastering technique of CPS insertion is needed. And Dr. Karvolkovic initially proposed the conception of a lateral vertebral notch. And so we inspired from this conception and developed a lateral vertebral notch referred technique of CPS placement and evaluate the safety and accuracy of this technique. So firstly, we determine
Professor Cao, there's no change about your slide. It's just stopped it at the beginning slide here. Can you just make it full screen? Yeah, you can full screen your slides, okay?
Okay, so shall we start again?
I think you can start it from the slides you just mentioned that. Yes, full screen that. No full screen.
Okay. Could you say my slide? Could you say my slide?
Yes, but it's in you have to full screen your slides.
Put the slideshow mode.
Yeah.
There's no change.
It's show mode. It's show mode. In my top left, it's show mode.
No, we just see the original mode.
It's very, very weird.
We click on the play keynote. Now we can see the full screen.
Okay, just let me try again. Okay, let me try again. Mm-hmm.
贝康共享屏幕。
Yeah, no, I just
Yeah, then click on 播放 so we can
yes,
see.
yes, I know. It's okay. Could you see this slide?
It's not.
It's not a
Play.
full screen mode.
Yeah.
Please show the first screen.
Yeah, this is the first screen. Yeah, this is show mode.
No, we can
No.
see.
No first screen.
Kai, if
Oh,
you're not
really?
able to change that, I think we can go ahead with the same mode so that.
Oh, it's very. So I try again.
Use iMac or Windows.
Windows.
Windows, I think is.
Yes.
Yeah.
Yes.
Right.
Yes, that's done.
Mm-hmm.
Yes.
Yes.
Yeah, Professor Cao, please continue.
Okay. The several techniques including the freehand navigation, but I can't. Oh, my slides is blocked. I think my slide is blocked.
We can see the slides named lateral vertebral notch on that slide.
Yeah, I know. There's some problem.
Okay, could you just fix your slides and we will move to the next speaker, Dr. Yang Junsong.
Sure,
Are you ready now?
Sure.
Okay.
Yeah, sure.
Let's invite Dr. Yang Junsong. His topic is perfect keyhole craniotomy, or what he very good at that procedure. Professor Yang, please.
Okay. Could you see my slide?
Yes.
So, dear moderator Joe, and thank you so much for the President Swing and the President Chao to invite me to give a speech. So today I'm from Xi'an Honghui Hospital. So my name is Junsong Yang. So my topic is to find the key and dig the hole. How to perform a perfect keyhole craniotomy. So I have lesson to discuss. So firstly, I want to ask everybody a question: is the discrimination the same as the cervical spondylotic radiculopathy? The answer is absolutely no. So why? Because I want to refer to this picture. So for some, the cervical CSR, the cervical spondylotic radiculopathy is not only by the disc herniation. For the elderly patients, the Lusca joint hyperplasia, even the collapse of the invertebral space, it could be caused the osteophyte.
Dr. Yang, your slides not moving.
Not
just
moving?
fix on, just fix on the first page.
First page. So first page.
So I think there's the same problem with my slide.
But actually, it's moving for me. But I can say I share the PowerPoint, but I also open the.
Yeah, the same problem with me, and I can see my slides go ahead on my laptop, but your guys cannot.
So how I fix this problem? So I just share this again.
Please try again.
Nice. So that's the move. It's move.
Yes. Yes, move.
So it's okay now.
It stops.
You can see I just played my PowerPoint now. Does it change it in your screen?
No. No.
Oh gosh. Is it right?
No. Can you just show your slide like this?
It's okay. It could be this.
Yes, it's okay. Just go ahead.
Okay. Okay. So just like this. Okay. So when we talk about this, the cervical spondylolistheal reticulopathy, so I will refer to this picture. For some patients, the CSRS could be mainly due to the disc herniation. For some patients, for the elderly patients, the collapse of the vertebral space could cause the hyperplasia of ankle vertebral joint, even the osteophyte located at the lateral mass. So when we talk about the surgery, we can do the anterior surgery. We can also do the posterior surgery. But in my opinion, the posterior foraminectomy is the minimally invasive surgery, can provide the direct decompression for the nerve roots. So when we talk about the keyhole surgery, have to know the anatomy of V point. In my opinion, it's actually the lateral margin of the interlaminar ventral. So we can easily to find this the V point is actually located at the lateral margin of the interlaminar ventral. But we have to know that the interlaminar ventral can be changed with the cervical extension and the flexion. So if you want to easily find the V point, you have to make the patient's leg. If you want to do surgery, you have to make the neck slightly flexed. So when we talk about the V point, why we call this V point is actually the interlaminar ventral, the laminar line, the conjoint point is actually the same as the character the V. So the second question is the range of decompression for the cervical disc herniation, the same as the loose cut joint osteophyte. I want to refer to this picture. When we look at the blue area is actually the disc herniation. The pink area is actually the osteophyte located at the ankle vertebral joint. So if we want to do the disc discectomy, we have to slightly retract the dura. But if we want to deal with the bony, the loose cut joint hyperplasia, we have
I made both parties. He didn't make it one-sided. They made it. He was angry. They were also at fault. He was also at fault. They weren't at fault. They were. Yeah.
Okay. So we have to enlarge the decompression area.
No idea. If you have to be the black, I don't know how he'll think. It's all. When you're not in that situation, it's overdone. Everything. You are a woman and all that. People who speak I've seen a lot of this women speaking doctors, this, that, and they wouldn't have. Somebody would have suffered, but they want to take the benefit out of it.
So could I go on or just wait a moment?
Please go on.
Okay. So, okay. So could you see this? It's moved now. It's moved now.
Go on, please.
So, okay. So when we took the third question is the keyhole decompression. The bigger will be better. So why I choose the endoscope surgery, because it have the 15-degree or 30-degree the view angle, so it's easy to detect some medial patch. When we rotate the endoscope, it can also expand the surgical view. So we use the endoscope, we can expand the surgical view. And the third, I want to use this picture because we have to know the anatomy for the intervertebral foramen. Actually, the intervertebral foramen for the cervical spine is like the funnel shape, like this. So we just need to use to open the medial patch, the intervertebral foramen, so it can provide the enough decompression area for the nerve roots. So in this picture, you can see the red area is a disc. The green arrow is a loose gut joint hyperplasia. So we just need to open the medial path. It can provide the sufficient decompression area. Another one I want to refer to, when we talk about the foraminal stenosis, the PEC system and the Keong system is based on the sagittal view and the axial view. But in my opinion, I have to remember the morphological classification for the intervertebral foramen. Some patients, they have a parallel sign for the intervertebral foramen, but some case it's a funnel-shaped sign. So it's different. For the left side, for the patient with a parallel sign, you have to enlarge the decompression area. But for the funnel sign, you have to need to open slightly. The decompression area is smaller than the parallel sign. Why I choose the endoscopic surgery for the keyhole surgery? Because the mostly common surgery for the keyhole surgery is leg root injury. So some patients was done the surgery under the microscope, but the microscope is different from the endoscope, because the endoscope we can use a small incision, but this is not. But mostly importantly, we can insert the endoscope into the incision like this. So with the rotation of the endoscope, we can expand the surgical view. The second one, because the endoscope surgery is with the continuous line irritation, so it could be provide the continuous and clear surgical view. So it's easy to prevent the nerve root injury. Some case when I open the keyhole surgery, we can see some nerve root is covered by the ligament structure. So actually, it's the meningovertebral ligament. It's the so-called the Hoffman ligament. It fixes the nerve roots like this. So if we want to do the keyhole surgery, you have to release this ligament structure. You can provide some space for retract the nerve roots. Some case we can open the keyhole. You can find the nerve root. It's just like this. It could be some surgeon will have the question: could it be the conjoint nerve root? Actually, use a picture. I want to ask everybody, where is the disc, or where is the nerve root? But when I done the surgery, we can see the picture. The right side, you can see the nerve root. Yeah, it's like the conjoint nerve root. But we have to refer to this picture. Is for the anatomy. The nerve root is actually consists of the posterior root and the anterior root. So it's a normal structure. When you open the covered ligament structure, some case you can find the two roots of the nerve roots. So for the keyhole surgery, another key point is how can we find the disc, the herniated disc? You can use this picture. You can see the yellow area is the nerve roots. The orange area is the pedicle. You can see from the cranial side to the caudal side, the disc space for the blue area is different in each level. So you have to remember this sentence. The sentence. You always can easily find the herniated disc in the axillary portion, because you can see this picture. This is a C5 C8Q1, this is a disc. It's just below the nerve roots. So for that take-home message, I want to use the 3 key points. The one is the spine endoscope. It's really beneficial for the posterior nerve root decompression. You can see this. The osteophyte, if you do the anterior surgery, have to the total ankle vertebral joints. But if you do the endoscope surgery, you can use the ultrasonic osteotomy or the diamond burr to do the decompression from the shoulder area and the axillary area. So it's easy to do the bony decompression. The second one I want to use, I want to say the pediculoplasty is the key point for the posterior endoscope surgery. You can see this. When we done the pediculoplasty, we can create, expand the compensation area to retract the dura and the nerve roots. It's quite safe to do the ventral decompression. The third one is the necessary. It's necessary for the ventral decompression for the foraminal stenosis, because if you want to down the keyhole surgery, no matter how large the keyhole you down, the keyhole can be healed in the long-term follow-up. So if the patient have the foraminal stenosis, you have to try your best to do the ventral decompression. So this is my presentation. You have to remember the key and find the key points and dig the hole on the cervical spine. When you insert the endoscope into the incision, you will find the surgical view and the endoscope is really fantastic. This is my presentation. I'm from Xi'an. So thank you for attention. So moderator Joe, I've finished my presentation. Thanks.
Okay, thank you, Dr. Yang. Wonderful speech. So Professor Cao, are you ready now?
Yeah, let me try again. So could you see my slide?
Yes. You can just start like this,
okay,
like
and,
Dr. Yang.
Yeah, I'm Cao Kai. I'm very pleased to share my experience perform a perfect cervical pedicle replacement. And as we know, there's various techniques, including freehand, navigation robots, CD cutter, screw guide templates, has been developed in placement cervical pedicle screw insertion. While this developing of this technique that can augment the accuracy of the CPS insertion, but the mastery in the freehand technique allows the above-mentioned technique to reach their full potential, improving the patient's report outcomes. So currently, the freehand technique are still prevailing in the particular scenarios. So find a consistent anatomic landmark and develop a practical and easy mastering technique of CPS placement is needed. Dr. Karikovic initially proposed the conception of a lateral vertebral notch. So we are inspired by this conception and developed a lateral vertebral notch referred technique of CPS placement, and evaluate the safety and accuracy of this technique. So firstly, we determine CPS entry points and the trajectory based on the coronal multiplan reconstruction image we call the CMI CT scan. And then we confirm this technique on the cadaver specimen. And finally, we confirm in our clinical work. So as a stage 1, we include 40 volunteers in this study. And we performed the coronal multiplan construction image. This image is compact the multiplane into one coronal plane to show the lateral vertebral notch. So the CMI can clearly show the HLVN from C3 to C7, where marked with the red color, So we measure the X1 and the X2, get the X. The X1 is a horizontal distance from the vertebral midline to LVN in CMI. X2 is a distance from a vertebral midline to the point of longitude pedicle axis, intersecting the surface lateral mass in axial plane. So then we get the X equal X1 minus X2, and then the value of Y is the vertical distance from the pedicle projector center to LVN level in the CMI, so that we can, through the value X and the value Y, we can determine the entry point. Then we measure the pedicle medial lateral angle and the pedicle cephalocaudal angle. Then from this picture, we can see the cross point of LPA to a posterior margin of lateral mass was almost at LVN in the sagittal plane. The value X and the value Y of the pedicle projector center related to the LVN from C6 to C7 was shown in these tables. So the entry point is just with an average of 2 millimeter medial to the lateral from C3 to C7, and it's above the LVN with average value of 1.5, and the value of medial lateral angle and the cephalocaudal angle is shown on this table. So in the stage 2, 12 human cadaver specimen was inserted with this technique, and the cortical integrity of each pedicle was evaluated by the anatomic dissection of the specimen and confirmed by the radiograph. And we can see we get a perfect insertion of the pedicle screw. At the stage 3, we included 86 patients who underwent 504 CPS instrumentation. The pedicle screw insertion, the pedicle screw position confirmed by a post-operative CT scan, and we assess the integrity of the cortex, and to classify this integrity from excellent to poor, and we give grade 0 to grade 3. That is in grade 0, the cortex is of integrity. Grade 1 is screw threads or less than 1/4 of screw cross section penetrated the cortex, and the grade 2 is more than 1/4, but less than 1/2 of the screw cross section penetrate the cortex. And in grade 3, and more than 1/2 of the screw cross section penetrate the cortex. So in after assessments, we find that just 4.9% of the pedicle screw position was in grade 3. This is the video of the manipulation of this technique. So firstly, we find the LVN lateral vertebral notch and drill to make sure the entry point, and use the hole to deepen the entry point. And then we use the prop to make the track of the pedicle screw until to the 2 centimeter, and then we use the feeler to palpate the integrity of the pedicle. So my slide is blocked again. Let me try again. And tap the track. And then after the tapping, I think there's some mismatch of the software.
Professor Tao, could you just skip that slide and go on?
Yeah, let me try. So let's look some cases. This is ankylosing spondylitis fracture dislocation case. We use this technique to insert in the pedicle, and from the CT scan after the surgery, we can see from the C5 to C6 the pedicle screw, the position of the pedicle screw placement is perfect. And this is another spondylitis ankylosing fracture and dislocation case. In this case, the all facets were fused, and the only landmark we can see is a lateral vertebral notch. And during the surgery, we use this technique to insert CPS perfectly and get the perfect reduction and the perfect position of the pedicle screw. And this is a C6 ABC case, and we conducted the posterior and anterior approach to use the CPS, instrumentation. And from the CT scan after surgery, we can see the position of the CPS is perfect. And this is another tumor case of the C5, and we resect the tumor from the posterior and anterior approach and reconstruct the cervical spine with pedicle screw instrumentation. And from the CT scan after the surgery, we can see the position of the pedicle screw position is perfect. So the common complication is vertebral artery injury. It's not common. It's rare. If you keep the medial lateral angle enough, the artery injury is rare. And another complication is cervical nerve root injury, and the last one is a spinal cord injury. Because the room between the medial wall of the pedicle and the dura is big enough, so the spinal cord injury is rare. So the lateral vertebral notch is a reliable and consistent anatomic landmark. The safety and accuracy of the subaxial CPS insertion by using a notch-referred technique are high and acceptable. Notch-referred subaxial CPS placement is easier mastering a practical technique. And this is our published papers. And thank you.
Okay, thank you, Dr. Xiao. Okay, after Dr. Tao's presentation, we just finished our second session focused on the posterior procedure in cervical spine. So any questions raised from the faculties or from the audience online? There's no online new questions. There's another question, I think maybe I think can ask Dr. Yang because there's Dr. raise a question how to ensure front otomy in ACCF, but I think is Dr. Chen, could you just answer that question? But I'm not very sure about the exact mean of this question. How to ensure from myotomy. I think there's a normal procedure to
I think this is a question from the audience. This last is a question for me. How do you confirm the trajectory in the coronal cord? Yeah, I think these are tips. There's some tips. When I perform the insertion of the pedic screw, how to confirm the trajectory in the coronal caudal plane, I always keep the when I insert the screw, I just keep the trajectory of the screw vertical to the lamina of the vertebra. So this is a tip when I perform this technique.
Okay, thank you. The answer from Professor Cao. I can see. Yeah, I think there's a question to Dr. Yang. How much facet can be safely resected in myotomy?
Thank you, Professor Zhou. So I think this is a great question. So some doctor will ask me how large is safe and how large is the efficient for the decompression. In my opinion, I think I have to protect the medial half. You have to protect the lateral half. So less than 50%. But in my opinion, I usually to protect maybe I only shave less than 20% because the endoscope surgery, we can insert the endoscope into the formula for the keyhole. Use the rotation of the endoscope. You can expand the decompression area without to open the outer margin. So sometimes in my case, I usually to do the post-operative CT scan. I can see it's like a funnel shape. The outer side is smaller and the inner side is larger. So it could be protect the fast joint. It's my viewpoint. Thanks much.
Thank you, Dr. Yang. So I think there's no new question here. So I think I will close this session and we will move to the closing remarks from Professor Cao Kai to end this webinar today.
And it's many thanks to our faculties and our online audience. Professor Zhou Feifei, Chen Huajiang, and Wang Beiyu share their expertise in the anterior approach of cervical spine surgery. And lots of thanks to Professor Sun Yu, Xia Tian, Zhang Hao, Junsong Yang, and me discussed the posterior approach. All faculties showed their surgical skills and their experience to deal with complications. And last but not least, many thanks again to APSS and CSRS-AP fully supporting this webinar. We hope we can cooperate with APSS again in the coming future to conduct the scientific webinar with faculties from China Spinal Society, and we hope we encourage all the spine surgeons to attend the APSS annual meeting to 2025 held in the Kuala Lumpur, Malaysia, on the 20th June next year. And I think it must be a very wonderful annual meeting. Thank you very much.
You. Okay. Bye-bye.
See you. See you. Bye.
Bye.
See you next time.
Okay, see you. Bye bye.
Okay, bye.